Good afternoon and welcome to the Independent Health and Aged Care Pricing Authority's online webinar on aged care cost collections. My name is Julia Hume and I'm the Executive Director Costing and Data Infrastructure at the Independent Health and Aged Care Pricing Authority, or IHACPA as it's known for short. Presenting with me today is my colleague James Chen, Director of Aged Care Costing. Good afternoon, James. I will start this presentation by acknowledging the traditional custodians of the many lands on which we are meeting today. I'm on Gadigal. For me, it's the Gadigal people of the Eora Nation. I recognise their continuing connection to land, water and culture and respect the elders today and those who walk in spirit. In today's session, we'll be introducing IHACPA's role in aged care cost collection, followed by a live question and answer session. Before we start, can I direct your attention to the Q&A widget in your browser window, which you can use to post questions to James and myself. You can also upvote other audience questions that are of interest to you. So please feel free to post questions during the presentation prior to the commencement of the Q&A session. Now let's start. I'll hand over to James, who will provide an outline of the aged care cost collections. Thank you, James.
Thanks, Julia. So welcome to this webinar on aged care cost collections. My name's James Chen and I'm the Director of Aged Care Costing here at IHACPA, and I'll be running through the slides today. So just to begin, I think I'll go through some of the background as to who we are and what we do. So as part of the National Health Reform Act, the Independent Hospital Pricing Authority was established in 2011, so originally known as IHACPA. And a lot of people will probably still refer to us as IHACPA on the odd occasion. In 2022, amendments in the NHRA Act and the Aged Care Act expanded IHACPA's remit into pricing advice for residential and in-home aged care. The main work programs of IHACPA, which is now known as, are to promote and contribute to the improved efficiency in and access to public hospital and aged care services through provision of independent advice to the Australian government. And more specifically in the aged care sector, to provide advice to the Minister of Health and Aged Care to inform the setting of residential aged care and support at home program prices. So the aged care landscape is quite complex with several key players. They're responsible for the governance of the system as a whole. So the key government agencies who contribute to the governance of the aged care system are shown in the graph on the slide. So these include the Department of Health and Aged Care, and the Aged Care Quality and Safety Commission, the Australian Institute of Health and Welfare, the Australian Commission on Safety and Quality in Healthcare, the Inspector General of Aged Care, and the National Aged Care Advisory Council, and the Council of Elders. So more specifically in relation to pricing, and IHACPA's role, as mentioned earlier, is to provide advice to the Minister in relation to aged care. So the Department of Health and Aged Care is the systems operator. So what that means is they'll implement the funding and the pricing, while the Minister for Health and Aged Care will set the price following our advice. So what is costing? Costing is the process of allocating a financial value to account for the resources used in delivering care to a consumer based on the individual's need. So it's really important for us to understand what drives the cost of delivering care. So that may be because of staff time, the types of staff, any interventions or products that were being used as well. So the more accurate and granular we can be with how the costs are provided, the more we can understand about the different needs of the consumers, which will ultimately lead to better and more accurate prices. So as part of the price setting cycle, cost collection is an important step. So this diagram shows the pricing cycle that IHACPA uses. So policy leading into classifications, which then starts to define what we want to collect in terms of costs, the actual cost allocation process, and finally the price, which is based on off the cost data that we collect as one of its key resources. So I've mentioned it before, but accurate cost data underpins accurate price setting. So cost data collections are informed by policy and public consultation, and are used to understand cost drivers and the variation of costs within the sector. So cost and activity data is used to provide evidence-based price advice and to refine the classification over time. So costing is really important. So costing is really important because costing enables us to understand the variations in delivery of care across different services, patient demographics, and classification groups. So collection of costs enables us to create a broad data set showing differences across the sector, which forms the basis of price setting. Also, as mentioned, informs the refinement of classifications. So now more specifically into residential aged care. So just some background into the residential aged care space. So as mentioned earlier, in October 2022, the aged care sector transitioned from using the aged care funding instrument, ACFI as it was known, to the Australian National Aged Care Classification Model, so ANAC. In 2023, IHACPA conducted cost collections for residential aged care and support at home, which contributed to the development of data collection specifications and data acquisition methodologies for the aged care sector. So collection of quality and representative data, including costs, time and activity data, is paramount to allowing IHACPA to provide advice to the Minister in relation to aged care pricing and costing matters. The data collection exercise will form the basis of future pricing, and classification development work that IHACPA will carry out. So the residential aged care costing study included a rigorous sampling framework to ensure that data collected was representative of the diversity of facilities across Australia. So we considered location, the ownership structure, so for-profit, not-for-profit, and government-owned, the size of the facility, and the needs of the resident. So expressions of interest for participation were sent to 989 residential aged care providers in January of 2023, and participation was voluntary. IHACPA worked with facilities to ensure that we were able to support them as much as possible. And with 118 facilities agreeing to contribute data to the residential aged care costing study in 2023. So as mentioned, the looked at facilities that are broad spectrum of size, remoteness, ownership structure, and specialized service type. So in the residential aged care costing study, we had collection of time data within residential aged care facilities over a period of 30 days. So it is a complex process where we're trying to understand the resources that are being utilized for a resident. So within the aged care sector, time was seen to be one of the key drivers of cost. So what we had was collection of some financial and operational data to inform the costing process, and participation with sites. Participating sites, they were provided with insights from their facility about their facility at the end. Data has been aggregated at a level that ensures anonymity of residents and staff members, and the final report was published on our website. So following the residential aged care costing study, IHACPA is looking to implement an ongoing cost collection process. So what this will ensure is that there's the most recent cost data that we can use that's reflective of what's happening in the aged care sector, which can lead to more accurate pricing. As such, IHACPA will be starting a cost collection for the 2024 in the coming months, and we're currently recruiting participants for the 2024 cost collection. So it'll be a similar time in motion study to the 23 collection, where we're looking at the utilization of staff, but we're hoping to be able to have a larger and more robust sampling target to capture all the nuances in the differences in aged care facilities. So why should you participate? So participating facilities will receive, the cost of data will influence pricing to the government, pricing advice to the government. You will contribute to our understanding of the cost that's required to provide care to a resident on an ongoing basis. It'll be part of the ongoing development of aged care costing standards, so standard rules that we'll have for allocation of costs and how we're going to do that going forward. And you'll receive a facility data insights pack. So what this means is you'll have the costs that we've collected specific to your facility, and we'll provide that to you as well. And so just to quote one of our participants from the 2023 study, I feel that it's pertinent to ensure that we are capturing a true reflection of the complexity of clinical governance required when overseeing care for our residents. So it's good to see that we've had a lot of positive feedback, but again, we all know that the residential aged care space is quite complex and quite varying, and your participation will be invaluable to our deliverables. So moving on to the support at home space. On to the 25th of October 2022, the federal budget expanded our function to include the provision of pricing advice and support at home aged care services. The new support at home program will be implemented from 1 July 2025 and will provide pricing advice for the schedule of in-home aged care services based on available data and advice on how pricing of in-home aged care services can be refined over time as more evidence emerges on the cost of service delivery. We've got another quote from someone who participated in our 2023 collection there. So, influencing change in the sector, it is important the aged care industry continues to provide data on care needs, staff time to ensure funding of its sector is reflective of the cost of delivering care. So, the 2023 study formed an introduction to the support at home landscape to understand the sector's existing cost structures, their current infrastructures, business systems, and programs used by providers for data collection and reporting. So a total of 48 in-home aged care providers participated, and what was in scope for this piece of work was the providers who supplied Commonwealth home support programs, home care packages, and short-term restorative care. So in 2024, similar to the residential space, we are looking at moving towards an ongoing cost collection process for support at home services. So the 2024 support at home cost collection will leverage the findings of the introductory support at home costing study from 2023 to develop a comprehensive cost and activity data set, the in-home aged care sector. So through the 2024 cost collection, we'll seek to refine previous costing study approaches through expanding costing study participation, refining costing methodology, improving data quality assurance methodologies, and looking at recommendations on how we can make this a more regular cost collection. And we'll include, we hope to include, again, Commonwealth Home Support Program, home care packages, and short-term restorative care providers. So why should you or your facility or provider participate? Increased representation across underrepresented geographical locations, provider types, and service types will help us have a more robust costed data set. It helps us build our understanding of the current services, the data maturity, and the business systems, and the drivers of cost variation. It'll help expand our data sets. And similarly to the residential space, you will receive your facilities data insights pack, providing you with benchmark costed data summaries. So just a quote from our previous study participant, it's good to be part of something that can support and improve the aged care industry, which I think rings very true as to what IHACPA is aiming to do. So the next steps, ultimately the goal of our cost collections is to obtain accurate cost data to inform price advice. As we move along the journey of cost collection, we hope to be able to enter a more regular and standardized cost collection cycle, ensuring and your participation will help form this journey, ultimately leading to costed data sets that are more accurately represented, the costs that are incurred across all residents and clients. So if you've got any further questions or would like to be involved, please do not hesitate to contact me on the email listed, and you can subscribe using the QR code for any future events as well. And I will hand back over to Julia.
Thank you very much for that, James. Unfortunately, I do have a couple of messages saying some people have found that a little bit hard to hear. So I hope people were able to resolve those issues around sound, and apologies for that.
Can I just jump in there? Yeah, we do have a recording of the of it live on IHACPA's YouTube site. So if there were technical difficulties, it may have been from our end or from your end, but you can always go back to reference that, and it is of the same presentation.
Yeah, thanks, James. And we will let this session is also being recorded, and we will make this available as well and send out a link to all participants. So we've got a number of questions which have come in, and James and I will endeavour to get through as many questions as we can today. And if we don't get through the questions, then we will provide responses later on today. We'll write some responses. And we're also happy to take further inquiries as well. So the first question I'll answer is, when will the next financial year's AN-ACC prices be released? So that's the 24-25 price, I think we're talking about in that question. So IHACPA in the process of preparing that advice, and we have developed a draft of it, and it's undergoing further Q quality assurance processes, and I expect it will be released in the next couple of months, noting also that IHACPA provide advice to the Minister, and which is then considered prior to the Minister releasing that advice. And we do work very closely with the Minister in relation to that. Which leads me to the next question, which is, does the Minister have to accept your recommendations, or can they choose to ignore it? We provide advice, and there is, and to the Minister, and the Minister gives it consideration. I don't think that they would ignore the advice. They may choose to implement it as they see fit, but there's no obligation for them to use it, and I don't think it would be ignored either. James, can I ask you a question now? What extra data will you require from providers that is different to the QFR or benchmarking data which is provided to Stuart Brown?
Yeah, so that's a really good question. So what we're looking at specifically, and I can probably speak on the residential space first, is we're looking at how the resources are being utilised at a individual resident level. So, what proportion of the total nursing time is being used for a resident at a certain AN-ACC class. And while the Stuart Brown data and the QFR data is quite good in providing us, rolled up costs, where we can see the total amount spent on, say salary and wages for nursing or allied health, but we're unable to understand the breakdown of that according to a resident level, where we want to try and understand the variations within, an AN-ACC class 5 and how the resources being utilized through that at a facility are different from an AN-ACC class 2 within the same facility. So that's kind of what we're really looking at. And, the extra data that we're looking at from the residential space is we're really collecting, the time that specific staff are spending with residents, and the types of staff that are using their time to spend with residents for care. Similarly, for the in-home aged care sector, that provides us some really great high-level data and rolled up costs of the total expenditure. But in terms of the specifics of how much it actually costs to deliver an hour of, nursing care, and that includes, the various transport, the various materials that are being used as well, aren't being broken down. And as we move forward, we really want to understand how that looks at a category and subcategory level. So then that cost data can provide some really good information for the pricing team. I think we've got a similar question from Stephanie, probably following on about the 2023 study with the data insights pack. Sorry that you haven't received anything yet. We have started to roll out and provide those insights packs for all participating residential facilities. We have had a lot of different contact points, and they may have changed. So if you want to send me an email or make contact outside, then we can definitely follow that and make sure that you get that insights pack for your facility. So I think
James, there's another question come through talking about the impact that participating, especially in the residential aged care cost collections, has on providers. And the question is, the aged care sector is already short-staffed. What impact will this additional reporting cost collection have on providers? IHACPA is very aware of the challenges around staffing and resources within residential aged care facilities. And we really do try to ensure that projects that we implement to undertake this cost collection are as least burdensome as possible. However, we know that it is not without an impact on staff. We really try and talk to people about, through participation in the study, we do get a better understanding of the cost of delivering care for residents, and as we do repeat studies, we also keep on learning from what we've done before and continue to implement projects where we've learned, like whether it be implementing the project, the setup of the process, trying to improve the ways that we do that.
Yeah, thank you. I've got a question here from Deb. So if ANAC classifications are not correct in their costings, e.g. people with behavioural and psychological symptoms of dementia, how will IHACPA be able to assess the true ongoing costs for this cohort of care? So we are really bound by the classification system of ANAC, and we understand that there are certain, clinical areas of ANAC that aren't may not be seen through that classification. IHACPA's role is to ensure that, if there are variations of costs, that we are trying to understand those and understand the reasoning for those. So we will, we work ongoingly with the Department of Health and Aged Care to understand, some of the feedback around what they believe to be cost drivers of care that we should look at. Additionally, there is an opportunity within consultation that happens every year to outline some of these concerns, and IHACPA can definitely start to look and investigate that as well, as to if there's any other drivers of care that we should be considering when costing and pricing.
Thanks, James. Can I ask you another question in relation to how facilities and support at home providers are able to use those benchmarking reports?
Yeah, so the benchmarking reports provide, I guess what we're looking at for resi and support at home is the average cost that that facility or that provider is operating at. And we'll provide the averages for the sector as well, and in some instances, similar cohorts as well. So if you're a rural provider in a certain M classifications, we try to provide as much information as we can, comparing to similar facilities. I guess it's an opportunity to understand your, the facility's workflows and how it, compares against the greater, the larger cohort, and for you to make, decisions around that as well, to understand, how the care is provided at your facility or provider level.
Thanks, James. Perhaps that, going back to the presentation that you gave as well, James, and there's a couple of questions around, do we work with Stuart Brown to understand like the reports that they are producing? And also one in relation to like, why can't we just use the QFR to do, or a Stuart Brown submission to undertake these cost collections? And if I can add to that, another question came through, like what does participation look like for a support at home or community provider?
Yeah, so I think I touched on it before, but we're all about trying to understand the specific costs incurred when delivering a service and the variation that that has across, either a service category type or an individual resident. So, the QFR and the Stuart Brown reports provide a lot of overarching information, and they're quite valuable, but they're unable to show us the difference that, thinking about Resi specifically, what does how does the care and the costs for an ANAC Class 8 differ from an ANAC Class 2 within this specific facility, and it's unable to break that down. I guess the second part of what it looks like to participate. So in the support at home space, what we're looking for essentially is to data around how the number of services that was provided within a financial year, and what we're looking at that is marrying that up to the ACFR, and then understanding the costs associated with each unit of activity. So we're trying to make that DRS and the data that we get from you as simple as possible. So we are trying to work with providers to understand their existing data collection pieces of software, or how you are collecting that information, and to make that as easy of a submission as possible. And we do understand that everyone has slightly different data collection, data keeping for that regards. And in some instances, it doesn't quite match up with what we have, but we will try our best to make sure that data is usable.
Thanks, James. And there's another question here, saying it's difficult to conceive how a support at home provider can report meaningful information at the category or subcategory level when management systems are not configured for categories as a metric, as support at home rules are not set yet. How have your team been able to consider that when undertaking costing studies?
Yeah, so we're looking at the available information that we have, and occasionally that gets rolled up into, the subcategories might not be collected and the categories will be collected, and where we will look at those. If there is any indication, after some consultation with the providers, rough breakdowns or estimations of breakdowns, we can use those as well. But I totally understand that the sector is not capturing activity if they haven't been asked to do that yet, and if those categories haven't been well defined yet. But it's something that we work with a provider on an individual level to try and understand, and hopefully produce something meaningful, and any data that's is able to be provided to us in terms of the activity, whether it be at different service levels, will be used. Additionally, if providers are capturing service level data in different ways or different, meanings. So, nursing or wound care might be listed under something slightly different. Then we'd work with them to understand what's being provided and what they're capturing, and try to map that against the service list that we're working towards. Thanks,
James. I'll just also note there's a couple of questions that we have about that have popped up about RADs. We will respond to those offline, just because that's a different area of the organisation, and it's not like the focus on today's session, but we certainly will provide responses to those. There's another question here. Are you able to provide an outline of how IHACPA comes to the price? Thanks for the question. I can see a number of people have also voted it up. Currently on IHACPA's website, we have the pricing advice that was used for the 2023-24 price, as well as the initial pricing advice that we delivered, as well as the technical specifications for how that price was developed. And those specifications really step through what data was used, what considerations were taken when developing the price. And we certainly do use the cost data that we've collected, as well as the larger ACFR data sets, and other relevant information to go into that price advice. So we can circulate the link to those technical specifications as well. There's another question here. Yeah, sorry, James.
I've got a question here from Georgia around minor capital costs being considered and collected as part of the Support at Home study. What we're working off is what's being reported in the ACFR. So I believe there are certain capital categories within the ACFR, and we are capturing those.
Cool. There's a couple of questions here. Firstly, do we, IHACPA, believe the current ANAC is sufficient? Providers are still running at a loss even following the uplift in December. When do you expect the ANAC rate to actually reflect the cost of care, as it is, the question states, as it clearly isn't. And then another question, the ANAC rate was inflated to account for the backdated element, July 23 to December 23. Will the CPI in July be expected to be lower to account for this? We are preparing budgets, and it's difficult to know. And I do understand that the challenge associated with preparing for 24-25 without final decisions around the ANAC funding. In relation to, is the current ANAC sufficient? IHACPA is preparing ANAC prices price advice based on what costs we can see being reported by the sector. We also know that there has been changes in relation to minimum care minutes required. We do consider that when we are preparing price advice. And we do also continue to monitor the price advice that we've provided and ACFR reports to compare what the price is as well as what expenditure was. But as the price is developed on the costs associated with delivering care, we do think that that ANAC price is reflective of the costs associated with providing care.
Thanks, Julia. There's a question around, so Helen's asked, am I correct in thinking that the Support at Home program has been delayed beyond 2025? At this point in time, we are working, that it's been announced, the government has announced for a 1 July 2025 start date. And that's what we're working towards. We are working towards whatever's in the public domain. Additionally, Rebecca's asked concerns over how the price is set and what is included in there, and is there any way I'm able to inform IHACPA on its future prices? So once the price has been announced, IHACPA provides a pricing framework and a pricing method document that's available on our website. And the last one is available on our website that goes through what's included and the methodology around that. If there are concerns, or if there's individuals or organizations that want to raise, criteria that for items that we need to be considering in our pricing framework, we do an annual consultation, and it's a public consultation where we will take that information forward and work that into our pricing framework. So we are sitting on the doorstep of this year's consultation. I don't have an exact date, but that will be available on our website and through our mailing list once that becomes public.
Thanks, James. There's a couple of questions here as well. So the first one is, staffing costs are by far the bigger driver. Do you also consider the following on costs, other associated staff costs in pricing ANAC? Payroll tax, superannuation contribution, annual leave, long service leave, workers' comp, training and development, recruitment, uniforms, conferences, etc. And there's another question that's been posted about, can you explain what costing standards are? And I think those two questions together are quite meaningful because the costing standards that IHACPA will be developing in relation to aged care step out things like what are in-scope costs, and so that's going through general ledgers and identifying, which costs in those general ledgers are related to provision of care, and then how those costs should then be allocated to different residents in an aged care facility, and that could be based on their ANAC class. And at the moment, with the costing studies, we're looking at how much time those residents spend with staff. And that's effectively what the costing standards do, ensure that all in-scope costs are being considered when allocating costs to residents. And they also ensure that there is a reconciliation between what's in the general ledger and what's being reported as a cost. So we can make sure that the data going in balances at the end of the day as well. James, there's a couple of questions actually in relation to data security, and there's a question in particular. There was a data breach after a cybersecurity hack last year. Firstly, I suppose it's important to note that anyone that was involved in that has been contacted at this point in time, and also we do take at IHACPA data security and the protection of data, whether it be for an individual or an organisation, incredibly seriously. But James, what assurances can you share about the processes in relation to data security?
Yeah, thanks, Julia. So as just echoing your comments, that IHACPA takes data security very seriously. So moving forward, IHACPA has its own secure data management system, which is quite a robust system in terms of security that we're using to collect, to receive and push out any data towards facilities and providers. So I guess that's the first part, and that's quite a secure process in terms of getting access to that and being able to upload and download data from there. Additionally, we are looking at trying to simplify and basically make any data that we're receiving from facilities as de-identifiable as possible. So using pseudonyms where able, where all those mappings are stored securely in our secure data management system. ensuring and really going through, I guess part of it as well is from the provider and the facilities end, is to ensure that, we aren't providing individual names within, or any sensitive information, individual information in any of the data that we're receiving as well. As well as really setting the standard that we're not providing any of this sensitive data through less secure sources like emails, that we are using the portal that IHACPA has set up to be able to receive information as well as provide you information as well. So any of our data insights packages, which do contain your facilities informations, are being pushed through the secure data management system and the portal that's associated with that, just to make sure that there's no no potential breaches or security concerns, that we're using the most secure method that we have available to us. Thanks, Julia. We have a question from Ty around CHSP. So the feedback was that according to Dex data, providers are breaking even. And are we using Dex data to inform our decisions? So CHSP isn't included in the first price, and it has been delayed in terms of its inclusion to support at home. But we are continuing to collect data from CHSP providers, as I think it's quite good to have the sector understand what we need and get them involved early in terms of data collection. So then, we can build that relationship and understand the requirements. We are using Dex data for activity, but for the actual costs, we're in a bit of an opposite situation from our home care package and short-term restorative care providers, where the ACFR is mandatory for them, where they provide quite good cost data, but not a lot of activity data that we're looking to seek. That in CHSP, we've actually got a lot of activity data through the Dex system. But we are asking, in the 2023 piece of work, we asked CHSP providers to provide some more granular detail around the costs incurred for the delivery of their service. I think similarly, there was another question around CHSP and allied health, and whether we looked at the entire gamut of CHSP providers. We didn't look at we didn't collect data from the entire CHSP cohort. In terms of allied health data, we are looking at allied health data. In the first piece of work, we looked at allied health data as a single category. We have every intention to look at allied health in its subcategories, so in individual professions going forward. But for the 2023 piece of work, we just weren't able to get the granularity in both the cost data, and we understood some of the reporting. The providers reporting to us didn't have the breakdown of some of that allied health data into that subcategory level. But going forward, we are definitely looking at capturing data, especially from allied health, in that subcategory level.
Thanks, James. How do you weight the data you received from different providers? If one huge provider with big economies of scales is able to deliver lower costs, is that stripping ANAC from some other smaller non-profits, for example? And I think there's another. Yeah, could you answer that one?
Yeah.
So I think there's another question about quality as well, and using the terms inefficient and efficient. So I suppose looking at both of those things, economies of scale for large providers, perhaps, as well as different quality of care. How are those things considered in relation to cost collection?
So I guess that's why we are looking for a large sample and to understand the variations of costs across both, large organizations and small organizations. The methodology, I can't comment too much on the specifics of the methodology over how that final price is being set. That's done through our pricing implementation team, and the details of that, as I mentioned, are available on our website for previous years. But I guess that's part of it. We want to understand the variation of costs across different sectors, and we definitely take into consideration, what that means for the final price, and having that accurately represented. In terms of the quality of data question, Julia, When we get our data, we definitely run a lot of quality checks around the data that we get. So if there are any, big anomalies in what we see, we always go back to our providers and facilities to seek clarification. So, occasionally we will see some figures, some average time that's being allocated to resident that's quite high, or some time that's being allocated to a resident that's really extremely low. So we always go back to our facilities when we're collecting that data to understand why those things have happened, whether it was an actual event that occurred or whether there was an underlying reason. So, on occasions we've had really long interactions with, collected a lot of really long continuous time interactions with certain residents within a facility. And that's because they had an event and required sort of specialing over a long period of time. When we've collected, really, really low numbers that seem abnormal again, we go back to us, and then sometimes the resident's gone for gate leave, and we haven't been made aware of that, and we take all those factors into account. When there isn't a good reason, then we go back and we try to, we will strip out some numbers that seem, that may be as a fault of the tech that we're using to collect sort of the time data. Thanks, Julia.
Thanks, James. Just there, there's another question here in relation to, are we able to provide some clarity or assurance around dates for the October, for the price, which would also accommodate the increased staffing minute requirement from October 24. At this point in time, I don't have an exact date for that, but the information that we collected in last year's cost collection is being used to inform that advice.
Yeah. We had a question around dementia care and if those specific costs would be coming to us. So we, I guess the resident level data that we have is basically what's in the ANAC class, ANAC assessments. What, we in our consultation, we do get a lot of, I guess, feedback around, that the cost of delivering care to dementia specific residents is quite high. What IHACPA will aim to do is try to seek, have some targeted cost collections for facilities that have specialized dementia units and specialized dementia services to try and understand that cost variation within those facilities. And it won't be limited to just dementia. I think we'd like to understand costs for any of those specialized facilities. And I know some of those categories are covered off within the base care tariffs that are being allowed. So First Nations as well as homeless supplements within base care tariffs. So we will look to try and understand those, and additionally through any other areas of concern that are being, either brought to us through the Department of Health and Aged Care or highlighted through our yearly consultation process.
Thanks, James. What is the intended 2024 collection period, please, for residential and support at home, perhaps?
Yeah, look, we're looking at getting underway with our residential cost collection in the next probably month or two. We know that there's a lot of reporting that facilities and providers have, including the ACFR that happens and the QFR that happens. So we will work with all facilities to try and, work what's best for them. But I'd anticipate there to be quite a wide data collection period for residential. Giving some rough dates, I think we're looking at hopefully late May, early June start, and that will kind of extend out to possibly August, or if not further, depending on the participation rates. For support at home, we are looking at possibly something similar with collection maybe happening a little bit earlier, but again, we are just trying to figure out and work and plan to exactly what we want to collect to be able to be most efficient and in providing the data to our pricing teams. And again, our collection period will be over a few months, starting sort of in the next couple of months, and we'll work with providers to understand the best times and the timeframes that's reasonable for them to provide us data in.
And there's another question here about can someone that's participating or an organisation that's participating opt to not have their service costs information shared with other participants? To really clarify, we don't share that information with other participants. We do create sort of averages, and we might group by for-profit or not-for-profit providers. With residential aged care, we would look at an average and the spread of costs by ANAC class. But we don't share identifiable information with other people participating in the study. And if you would like to participate in a study and have concerns around where the data sharing process, we'd be very happy to discuss that with people to make sure that if you had concerns that they were met. Because it's our intention to maintain data privacy.
And can I add to that, Julia? Like, if I understand there's like a lot of variations in the demographics for providers. If we are collecting from a really small, specific, you may provider that has quite unique characteristics, we wouldn't provide any information publicly that would, isolate a single a single facility that can be kind of, we know the characteristics to work backwards to try and identify that. We definitely go and consider that. And, where we do have really small samples, we either suppress those in our public facing report while keeping that data for use within our own internal IHACPA, processes. Or we would look at amalgamating certain categories across with similar categories. I know for ANAC, in some previous times, we had quite low representation from certain ANAC class categories, 7, and where we've grouped 7 or 8 together to make sure that's not identifiable, and we may have had quite a small representation from M7 and M6s, and amalgamating those results together to make sure that, the results that we're presenting are anonymous and aren't able to be identified back to a particular facility or provider.
Thanks, James. There's a question here as well. Can we place an email address for getting involved in the chat? We will send all participants of today's webinar an email this afternoon, and that will include some of the contact details in relation to participating in future studies, so we can do that. Just knowing we've got 5 minutes left, James.
There was a question around food supplements. That's, there is food supplements, in terms of support at home and whether we will be collecting that data. Meal preparation and meal delivery are service categories that we are looking at, and we will work with providers to understand their costs associated with those. And we do understand the nuances with meal preparation, meal delivery. We are looking, the unit that we're looking at for those as being a single meal isn't always directly transcribable across the other services where they're looking at per hour. But we are working with providers to understand how that's, best captured.
Thanks, James. There's also a couple of questions around the service list and changes to the service list for support at home. someone said, I believe in the new world there will be no case or package management fees to be charged. How will those be compensated through the pricing? IHACPA is, we've had one foray into understanding support at home costs, and we will be undertaking a further costing study shortly. We're really interested in understanding the costs associated with provision of care, and depending on the definitions of items on the service list, make sure that all relevant costs are included. And so, that's, in the next 6 months, we hope to be achieving that or working towards it. Another question about do our recommendations include an allowance for surplus or profit to be achieved, or a rate of return? At the moment, our pricing advice is based on the costs reported, and we use the ACFR for that as a primary source. So if those costs are included in those reports, then that is what the price is then considering.
I think to follow on from that question, someone's asked, for support at home, what is your source for data collection? Do you use QFR and ACFR? And the answer is yes. The QFR and ACFR are our primary data points to understand the costs being incurred by support at home providers. And I think we've talked about it before. We are looking at additional information to understand at a more granular level how those costs are being utilised in the provision of care. But we are using them as sort of the base point. And I guess a large reason for that is to try and avoid double submissions. We know that the sector is quite busy, and reporting burden is quite high, and we're trying to utilize as much of the existing data that's available to us already in terms of this, to try and reduce that burden on providers where it's only really what's essential for us. Yeah, I think we're
Thanks, James.
almost out of time.
Yeah, there's one other question about, is IHACPA considering providers reporting is made mandatory through legislation? I think initially we're interested in improving quality of data and working with providers to do that. And we're not really, it's not our preference to be making things mandatory as such. I'd like to thank all participants. Thank you all for taking the time to join us today, and to allow us to introduce IHACPA's role in aged care costing. I hope we've been able to provide you with an understanding of our processes, and hope that any providers who are interested in being involved with the cost collections in either residential or support at home spaces or both, please express interest in the link we'll be shared via email this afternoon. It's also on our website. I hope you enjoy the rest of your day.